Thank you, Eric. Well, it's a great pleasure to speak about Radiology and specifically the work of the ACR GSCR Network VA Subcommittee. I'd like to thank ACR for giving us the opportunity to speak. We have no disclosures. So the topics I'm going to be covering in today's session are several. First, why was the VA Subcommittee formed? What are the goals of the subcommittee? Next, why is it important to have participation from radiologists in ACR? Next, how is ACR assisting VA radiologists? How is VA innovating in healthcare when opportunities are unique to VA? And lastly, how can a radiologist get involved in ACR? The goals of the VA subcommittee are several. First, exchange of ideas among VA radiologists and non-VA radiologists across the nation. Next, resource sharing. And lastly, project development. And I'll be discussing a project that the VA subcommittee is currently supporting through VA. This ACR VA Collaborative Initiative, this new initiative is historic. It's the first time in ACR's 100-year history that we've had a VA subcommittee, and it's thanks to hard work from ACR leadership staff and participation from VA leadership. I'd like to thank the growing members of the VA subcommittee. We have representation from coast to coast. We have radiology resident representation. We have representation from radiation oncology. I'd like to give special thanks to two dedicated individuals, Bob Pyatt and Eric Friedberg, who are the chair and vice chair of the GSR Commission, respectively. It's thanks to these two individuals that we have a VA subcommittee. The bottom line is we're extremely fortunate to have such a dedicated team of individuals working on this new landmark ACR VA Collaborative Initiative. So why is it important to have participation from VA radiologists in ACR? Well, VHA is the largest integrated healthcare system in the United States, over 1,200 healthcare facilities, 170 VA medical centers. It provides care to over 9 million veterans enrolled in VA's healthcare program. VHA is the nation's largest provider of graduate education. It's a major contributor to medical and scientific research. More than 120,000 healthcare professionals are trained each year through VA. Bob Sherrier, who's VA's chief consultant of documenting services, published a seminal report in 2012 that demonstrated the value that VA provided to radiology. This was work done through ACR's Committee on Governmental and Regulatory Affairs and Academic Radiology. And what he and colleagues found is that radiology has benefited substantially from VA's collaborative involvement with academic medicine, both in terms of the number of radiology residents trained at VA, as well as the uniquely rich clinical training experience that VA offers. VA is second only to Medicare and Medicaid in providing direct financial support for graduate medical education. VA invested nearly $2 billion in direct fiscal support to VA. Over 40,000 residents spent part of their training at VA. VA has a robust medical research network and encourages collaboration through private industry, other federal agencies, nonprofit, academic affiliates. And what Dr. Sherrier and colleagues found is that VA plays an important role in radiology training in combination with academic radiology programs. Bill Thorworth, who's the CEO of ACR, really put his finger on it when he talked about the unique opportunities that VA offers to the radiology community and healthcare in general. As he said, VA with their single medical record and long-term coverage of the VA population has tremendous potentials for evaluating initiatives like comparative effectiveness research, demonstrating the benefits of clinical decision support, and the development of meaningful, impactful performance measures. So tremendous opportunities exist through this new ACR VA Collaborative Initiative, and VA's perspective is actively being sought through activities being coordinated through the ACR GSA Network Committee. So how does ACR assist VA radiologists? Well, in several ways. First, advocacy. ACR does advocacy extremely well. VA was considering a proposal to allow advanced practice nurses and certified nurse practitioners to independently interpret advanced medical imaging studies. And ACR was able to convince VA to abandon this proposal. Community is another way ACR assists. ACR has a very rich community. For example, Engage was launched in 2016. This is a resource that allows radiologists across the nation to exchange knowledge and share solutions. A specific member of community called VA Rocks was developed just for VA radiologists. Another example of community, VA radiologists connect through an annual dinner at the ACR meeting called the Michael Donner MD Annual Dinner. And this is to thank Michael Donner for his work during the development of this VA subcommittee. Educational support is another way ACR supports VA radiologists by offering exclusive discounts on ACR education activities, such as through the ACR Education Center, the Radiology Leadership Institute, to name a couple. ACR also provides substantial reduction in dues to encourage VA radiologists to get involved. Professional development, ACR supports VA radiologists' participation in committee work activities at the local, state, and national level, knowledge resources through a growing network of VA and non-VA radiologists, and mentoring and network opportunities, the ability to mentor younger radiologists, and in turn be mentored by more senior radiologists. As I mentioned, the VA subcommittee supports global projects being developed through VA. One example is VA PALS. This is a VA partnership to increase access to lung screening. Drew Makaniki, who's a radiation oncologist at VA, formed this VA PALS partnership in 2017. He's a VA subcommittee member. And this work was amplified through the VA subcommittee in an ACR bulletin article called No Patient Left Behind in 2019. Lucy Spaluto, who's a radiologist at Vanderbilt and who completed a VA Quality Scholars Fellowship Program in Health Services Research, will be speaking on this global lung cancer screening initiative, VA PALS, that she's collaboratively leading through VA's healthcare system. Other global initiatives that assist VA radiologists include the creation of ACR's Commission on Patient and Family-Centered Care. They've developed resources such as radiologyinfo.org that serves over 1 million visitors per month, giving patients information on the procedures, providing videos and comprehensive descriptions to make their imaging study understandable and easier and very powerful resource. The ACR PFCC toolkit is also developed to encourage radiologists to become more patient and family-centered in their practice and provides hundreds of free resources. The ACR's Commission on Patient and Family-Centered Care was designed to help radiology professionals provide patient and family-centered care in their practice, and it works collaboratively with multiple ACR committees, including education, outreach, informatics, population health management, quality experience, toward the goal of improving patient care. Developing external partnerships is also extremely important to the PFCC Commission and ACR, again, toward the goal of improving patient care. Lee Becker, who's a former chief of staff at the Veterans Experience Office at VA and is currently VP Solutions Principal of Vidalia, is truly a patient and employee experience champion. And he'll be speaking on ways to improve the patient experience, discussing successful initiatives VA has developed and is using to improve patient care, as well as strategies that are useful to both VA and non-VA radiologists toward the goal of improving patient care. Other global initiatives ACR has developed to help VA radiologists include ACR's new Data Science Institute, taking a look at AI, Imaging 3.0, which allows radiologists to bring highly actionable initiatives into their practice to provide value to their patients, as well as leadership training through the Radiology Leadership Institute. And these are just several examples of important ACR initiatives that benefit radiologists in their daily practice. VA is an innovator. It has a robust innovation ecosystem. Elliot Siegel is truly an innovator. He's an expert in PACS and digital imaging, among many other areas. It's under his leadership that VA Maryland healthcare system became the first filmless healthcare enterprise in the world, and he'll be speaking to us today. So how can radiologists get involved? Well, at the local level, for example, in Milwaukee, we have the Milwaukee Rank and Race Society. This was founded in 1923. This is Andy Simon, who preceded me as the president of the Milwaukee Rank and Race Society. Most states have very active chapters within ACR. Wisconsin has a very active chapter where there's opportunities to get involved in committees on diversity, education, government relations, economics. At the national level, there's opportunities to get involved in operational areas as well as specialty areas. So why get involved? Well, in general, radiologists are leaders. We collaborate with patients, technologists, and colleagues each day. We're champions for providing quality care, for improving patient safety. Participation in both radiology and non-radiology medical organizations is very important. It affords opportunities for personal growth, professional satisfaction. Advocacy helps our patients. Participation builds relationships and trust amongst our colleagues. So get involved. Remember, your voice matters. I would encourage you to attend your local, state, and national medical organizations. Introduce yourself. Participation and advocacy is very important to the continued success of our profession. It improves the health of our patients. So please reach out to me or my colleagues to get involved in this historic new ACRV's collaborative initiative, and let us know if you have an idea or project that the VA subcommittee can support. Thank you very much.
Good morning. I'm Lucy Spaluto. I'm a radiologist affiliated with the VA Tennessee Valley Healthcare System and Vanderbilt University Medical Center. Thank you to the American College of Radiology for inviting me to speak at the ACR 2021 annual meeting. I'll be spending the next few minutes talking about implementing lung screening programs through a collaborative learning network in the Veterans Health Administration. I have no relevant disclosures. Although I will say that although I am an employee of the VA, neither the VA nor the White House are paying or supporting me to be here. The views presented today are my own. Some of the work I'll be talking about today is funded by the VA Office of Rural Health and by the Bristol Myers Squibb Foundation. So what is a collaborative learning network? It's a network of many parts that may be disconnected, working together to try to form best practices. The ARC also defines a learning health system as a health system in which internal data and experience are systematically integrated with external evidence and that knowledge is put into practice. As a result, patients get higher quality, safer, more efficient care, and a healthcare delivery organization becomes a better place to work. So a collaborative learning network can become a learning health system. Collaborative learning networks and learning health systems work together by aligning everyone with a common goal. In a learning health system, we have leaders who are committed to a culture of continuous learning and improvement. We systematically gather and apply evidence in real time to guide care. We employ IT methods to share new evidence with clinicians to improve decision-making. We promote the inclusion of patients or our veterans as vital members of the learning team. We capture and analyze data and care experiences to improve care. And we continually assess outcomes and refine processes and training to create a feedback cycle for learning and improvement. So why is the VA an ideal setting to establish such a learning health system? The VA is based on a value-based care framework. There's no better place to implement a learning health system than in the VA. There are 171 VA medical centers and 1,283 outpatient sites across the country aligned with a common goal to provide the very best care for our veterans. As you can see here, we have sites across the country that are aiming to serve the best care possible for our veterans. We are continually assessing our outcomes and refining our processes to create learning and improvement. One of the components of this improved care that we're providing is that it should be equitable. And what does this mean? Health equity means that there is an absence of avoidable, unfair, or remediable differences in health outcomes amongst groups of people, whether these groups are defined socially, economically, demographically, or geographically, or by other means of stratification. What this really means is that everyone has a fair and just opportunity to be as healthy as possible, that all veterans have the opportunity to achieve their full health potential, and that all of our veterans should receive the very best care, no matter where they live or what their socioeconomic background might be. To achieve health equity, we have to remove obstacles to being healthy, such as poverty, discrimination, and their consequences, such as powerlessness and lack of access to good jobs with fair pay. We need good access to safe housing and safe environments, and good access to healthcare. And what we must recognize with health equity is that some individuals and populations may require different types of resources to achieve this full health potential. An example of a learning health system in the VA is in progress. We are learning to implement lung screening across the Veterans Health Administration through the VA PALS program. The Veterans Affairs Partnership to Increase Access to Lung Screening, which is especially focused on bringing lung screening to rural veterans. We are working on improving lung screening across the VA through reviewing data across all of our sites, sharing evidence and best practices, and using this evidence to change the way that we all practice. We're continuously cycling and refining processes by sharing these practices across the VA. And of importance, we're involving veterans in the process and getting feedback from the veterans to make sure that we're providing the very best lung cancer screening experience possible. It takes a big team of people to work across the whole country in the VHA. This is part of the VA PALS team, not even the whole team. It's comprised of pulmonologists and radiologists and radiation oncologists, funders, IT specialists, nurse navigators, and that's just to name a few. So it takes a big team, a multidisciplinary team, a team of people with specialties in all different backgrounds to work together to continue to share these best practices. Some of the activities ongoing in the VA PALS program are creating a support network of weekly leadership calls and navigator calls. So our nurse navigators regularly meet to talk about how things are going at each site and what has worked at some sites and what may not have worked at other sites and how they can learn from each other. Same for program directors. Again, what's worked at your site, what might work at other sites. Working to develop a written guide for best practices for lung cancer screening. Providing quality assurance for CT scanners to make sure that we're providing the very best CT scans possible. Continuously providing education for our clinicians and our navigators. and anyone who wants to learn more about lung cancer screening. Clinically, the programs focus on recruiting patients who are eligible for lung screening, refining processes for shared decision-making, offering smoking cessation treatment, the actual screening process itself, and then the downstream follow-up. We collect data through numerous sources, including the VA PALS LCAP software system, the VA Corporate Data Warehouse, and program evaluation data obtained through surveys and interviews. And we're continuously measuring the reach of the program, the effectiveness of the program, how different people are implementing the program, and how it will be maintained in the long term. We've taken a very implementation science-driven approach to collecting, analyzing, and utilizing the data, making sure that we're considering all aspects of this evidence-based practice, how it's implemented, what the teams are like that have to work together to implement lung cancer screening. Some of this work involves quantitative data collected through surveys, assessing levels of readiness at different sites across the Veterans Health Administration, assessing the experience of veterans who have joined lung cancer screening programs, assessing the experience of providers who are working to offer lung cancer screening to our veterans. We're doing qualitative work through interviews to better understand barriers and facilitators to implementing lung cancer screening. We've developed process maps at each of the VA PALS sites to understand how they are enrolling veterans, how they are offering lung cancer screening, how they are following up on results of lung cancer screening. We refine these process maps every 6 months so we understand adaptations that different sites have needed to make. And then we can share these processes across not only the VA PALS VAs, but with VAs across the country so that we can adapt systems across the country to improve. We'll also be following clinical and process outcomes on number of cancers diagnosed, stage of cancers diagnosed. We have learned a tremendous amount from the veterans who have enrolled in this program. Some such quotes from veterans include, "My message to other veterans is do it, don't delay, and just do it, especially if you have a history of smoking. By all means, just do it. And if your primary care doesn't schedule it for you, insist they do it. I mean, it saved my life." So the impact that these veterans can have on the lives of other veterans is incredible. Another veteran says, "I had excellent doctors and excellent nurses, just terrific care at the VA. I was very impressed." And another says, "I am so thankful. Not only is my cancer cured as you can cure cancer, but the expense to me has been minimal. How can anyone possibly ask for more than that?" The voices of the veterans are so incredibly powerful to share with others who might want to enroll in a lung screening program. We've also learned from our navigators who are interacting with our veterans regularly, and more importantly, interacting with each other at these veterans roundtable calls so that they can share best practices and continue to evolve in the learning health system. One navigator says, "One thing I love about being involved in the VA PALS Navigator Group is the sense of community. The monthly navigator calls allow us to engage with one another and share information about each of our programs and how they are different. We work together as a family in order to make each of the programs work better." Another says, "Even though the lung cancer screening programs at VA PALS sites don't all have the same operational approach, they provide valuable advice and input to each other on ways to improve. It is very helpful having this network of sites to consult as we all progress in program development." And we've learned from our radiologists. The radiologists say the VA is still defining how lung cancer screening can be broadly applied, and we need to figure out how we're going to do this on a national level. So working in this learning health system to learn from each other so that we can all get better. We need to ensure the infrastructure is in place to do this within the VA as an integrated health system. And I would like to see us expand our program reach from large urban facilities to smaller rural facilities throughout the VA to ensure patients are screened and treated within the VA infrastructure that's available. We've looked at levels of organizational readiness at different sites across the VA and how this might predict how they're doing lung cancer screening. We've found that radiologists have a much higher level of readiness than those in primary care. And this has really tailored how we have approached educating our providers and rolling out our lung screening program, understanding that we need to work with primary care to understand what their barriers are to implementing lung cancer screening, to teach them more about lung cancer screening and the importance of lung cancer screening. And here's an example of one of the process maps that we've developed at the Nashville site. It talks about how we identify our programs and confirm patient eligibility, how we schedule their appointments and offer smoking cessation, how we communicate results. again, we've developed these maps for each of the 10 sites so that we can share the practices at each site with others who might be able to learn from them and figure out what might work at their site. It's this sharing that helps us learn and grow together. Thank you so much for your time. I appreciate it. And thank you to the Office of Rural Health for funding this very important work. If anyone has any questions, please don't hesitate to reach out.
Hello, everyone. My name is Lee Becker, and I'm pleased to be here at this year's ACR 2021. And I'm just really excited to be speaking to you about what the VA has done to improve the veterans' customer experience, and just share with you a case study around how the VA has been able to increase trust over the past few years since the crisis in 2014. Just special thanks to Dr. Weissman and, of course, the esteemed ACR and the panel and all the attendees. Thank you so much for the opportunity to share with you today. So, just jumping right in, when you think about what, when you look at this slide, this kind of highlights the incredible work that VA has done, to date. And we think about by implementing customer experience, by implementing patient experience, by taking in consideration that business capability, you can see what VA has been able to do, whether it is reducing no-show rates and able to increase over 3 million appointments, about $1 billion worth of cost avoidance, being able to get back into the system, increasing operational efficiency, of course, the trust, being able to move trust from a record low of 55% back in 2014 to now the VA trust levels at 80% overall and 90% for VA healthcare. Truly proud for all of you that are part of VA. I know you're very proud of that effort. And then, of course, employee satisfaction, just seeing the employee morale moving. The VA was rated 16 out of 17 of the largest agencies, and now the VA in just 2 years was able to move up to number 6 on the best places to work. So tremendous effort, and the amount of the ability to provide even better service to veterans by implementing experience, by listening more, listening better, is just truly tremendous. And what we found, actually, it has saved lives. Over 3,000 veterans, that the lives have been saved by just listening better. Well, this didn't happen by accident, right? So in 2014, many of you may have been a VA, or you are familiar with this crisis that the VA was embroiled with. It was really if you look at the final analysis of what happened, and we had a Secretary Bob McDonald who came into the VA. He came from private industry, from Procter & Gamble. And what we identified was we were missing this fundamental capability of customer experience. When you look at what happened with the crisis, where veterans were not getting seen at the right time, and veterans, as a result, were being harmed, whether intentionally or unintentionally, but just the reality of the situation is we did not know. We did not have the insights really directly from the veteran to know of these issues. We did not have the capability of really listening at scale and continuously listening to the needs of veterans across the entire enterprise to be able to understand where our gaps and challenges were. So as a result, the VA experienced in 2014 this reactionary state of, hey, we have this problem. And that's pretty much how VA was before 2014 as well. It was very much in this reactionary type of state from an enterprise perspective. So what we did was, with Secretary Bob McDonald, we introduced this notion of veterans experience, right? So just taking best in practice from industry around customer experience. We talked to, of course, Cleveland Clinic, Mayo, UCLA. We talked to some of the best in healthcare, as seen as the best in healthcare, Barrow Institute. But also what we found was we also talked to, we saw a lot of similarities even with those healthcare systems. So we talked to Apple, the industry, Marriott, all the best brands that we work with. And we found was, at a fundamental level, again, this notion of customer experience has to be implemented. And so what we identified, this was an aha moment for us, that when we start understanding a little bit more, okay, how does VA see itself? And VA sees itself in these silos. So you have VBA, which is benefits, VHA, healthcare, cemetery affairs, administration. But what you realize, and even within those silos of excellence or cylinders of excellence, there's other silos and cylinders within even within Veterans Health Administration, one of the largest healthcare systems in the world. And so all of that is this burden on the veteran, where the veteran sees VA as one, right? So the VA sees the VA as one, whereas we at the time did not see ourselves as that. So so then the question is like, okay, well, how do you implement, how do you ensure that you're able to provide this unified view and this unified understanding? If the veteran sees the VA as one, how can we ensure to orchestrate all that experience together? And the answer again is the customer experience piece. But it starts with really at the fundamental level. When we think about experience, it really starts with these three pieces, three kind of fundamentals. And then of course, the fourth being trust overarching. But the three fundamentals, the three E's is effectiveness, ease, and emotion. So effectiveness, as we think about, is, did I get the services I need? Was it easy to get the services I needed? Do I feel like a valued customer? Those are the three pieces. And the third one, the emotion, the feeling valued, feeling respected, that is the critical piece that enables experience. And all that drives trust. And so this was very important for the VA at the time when we had all these metrics, all these operational metrics, clinical, all these data points. But when it comes down to it, what veterans are really at the fundamental levels, what we found is those three E's. And that's really what then drives trust. Now, interesting point is the trust aspect. A lot of people have asked me, well, why are we measuring trust? Well, the reason for it is because veterans have said to us that trust is what matters most. If I trust you, I will utilize your services. If I trust you, I'll listen to you. And that has been so powerful. And I think during COVID, we've seen the tremendous adherence to the care plans, to the instructions that were provided by VA to veterans. We have seen that where, because of the high levels of trust, veterans were listening to those instructions across the board. And so that's just an example of where that happens, how it could correlate directly to healthcare, directly to healthcare outcomes. What I love about this right here, this is a great depiction, and I've talked about what the three E's from the veteran perspective, right? I got the care services I needed. It was easy. I felt like a valued customer. But what's amazing is that you could also flip this also for an employee perspective. And this is really important because the only way we can't just focus on, from an experience standpoint, just on the customer. We also have to look at the employee piece as well. And that is something very important, especially when we think about, you think about some of the challenges around as we're modernizing the electronic health record, et cetera. It's so important that we take in consideration the provider, the healthcare staff perspective as well. Do I have the tools I need, training I need? I feel empowered. My tools and systems work seamlessly, right? So those are the pieces that are really important. I know the VA is placing a lot of emphasis, with this administration, to really kind of even focus even more on the employee experience aspect, which I think will increase the experience overall even more as well. And especially now with, the realities of burnout, the realities of making sure that we're taking care of our providers. We need to make sure that we are addressing, all the aspects of how do we make the jobs easier for our providers to provide the very best care and services to their patients and their family members. So as you think about what how the VA has started implementing, so taking the kind of theory into practice, what the VA has done was able to, truly be able to understand the journey of the veteran. So here's a journey from the outpatient perspective. And because of the access issues, we knew that we had to really focus in on the outpatient aspect as a start. So we think about all the different clinics that the VA has, operates. What we found was it's really these 5 moments that matter. And you could see, it's the before the visit, the arriving facility, the during the appointment, departing, and after the visit. And what's fascinating is you look at the 5 boxes below, those are, you'll see elements of effectiveness, ease, and emotion, right? And you can see how it's baked in there. And this is how the VA is actually asking veterans and validating whether their experience is meeting the mark, right? Understanding what, from the veteran's perspective, are we meeting the mark to the moments that really matters to them? And this has been truly so valuable. And then this is another example of just, when you think about the responses that have come back to date, about 70% of the responses have been compliments. The concerns, about 19%, 13% are recommendations. You can see this kind of, again, it's percentage wise, so you can see it was averaged up, but you can see this powerful kind of notion of most of it. There's a lot of goodness that our VA employees, our providers, our staff are doing. What VA has done is taken those insights and actually shared it with their front lines to be able to then so that it can be utilized to understand, hey, how are we doing? Are we doing? And what's fascinating with the compliments and with the concerns and recommendations, most of those are actually positive in nature. It's not saying that, okay, you're bad. What it's saying is, hey, I have a concern with with the time of my appointment, as an example. I appreciate I got my appointment on time, time, but the time was not the right time. I'd rather it be, I'd rather have more ability to have my appointments in the evening, late afternoon versus in the morning, as an example, right? So those are opportunities, and we can then take that and make those improvements. So here's a great example of how the VA is implementing this capability, is continuous listening in real time. And you can see the different modalities across the entire journey. You can see it the entire VA, right? VBA, VHA, benefits, health, and the cemetery administration. And the different modalities and how we listen, and how the VA listens, and being able to then understand those needs and address those needs in this proactive way. Here's a quick use case to just show you just the power of this listening. Again, it could be as simple as this. Veteran goes to their appointment, they go to radiology, they would like to provide feedback, and then they provide the feedback, and that feedback is then ready immediately to the VA to be able to address it, whether it's at the individual service recovery level or at the level of thematically, and being able to understand the themes, the trends, and then be able to utilize that to see how can we make wholesale, holistic changes based on the veterans' insights. And what's powerful here is the verbatims that the veterans leave. Oftentimes that veterans don't leave just about radiology. They may say, they may be talking about different parts of their care journey, or veterans may actually share that they have, there's a quality issue, there's a safety issue, or maybe the fact that the veteran feels like they're not in a good mental health state. They won't even want to hurt themselves. And we've had those issues where veterans have shared that. And then we were able to automatically, using the artificial intelligence, to alert the Veterans Crisis Line that we have a veteran that needs dire help to engage to help them, that they're in crisis, or financial hardship as well. So that's the power of being able to listen and be able to take in all those comments to be able to then action. As you can see, this is in 2014, right? The VA was in this reactive state because the VA did not have this culture of this customer experience and this culture change that has permeated since then. As a result, since then, you can see with this capability, the VA has moved towards this responsive, proactive, and this anticipatory state, where the VA is able to then now anticipate the needs of veterans and use that to help then improve services across the VA enterprise. I'm excited to take some additional questions and happy to dive into deeper one-on-one with any of you to learn more about this incredible work that has been happening at the VA. Thank you so much for having me.
Hi, my name is Elliot Siegel, and it's my privilege to present at this session a discussion about opportunities for innovation and collaboration in radiology within the VA. I'm Chief of Radiology and Nuclear Medicine for the VA Maryland Healthcare System, and I am the lead for imaging for VISN 5, which includes Washington, D.C., the West Virginia, and Maryland VA facilities. I'm also professor and vice chair of radiology and nuclear medicine at the University of Maryland School of Medicine. Met often with skepticism by colleagues at the ACR and in academics and private practice about whether the VA truly is an organization that encourages innovation and discovery. And overall, what I found during my career is that indeed the VA has offered and fostered innovation and creativity, with major advances that have occurred in the VA even before academics and private practice. The VA has offered me the freedom to practice and innovate, removed from many of the constraints and many of the current reimbursement incentives and other challenges that are faced in academics and private practice outside of the VA system. And in fact, the American College of Radiology has traditionally had really strong support for VA radiologists, which I appreciate. I was selected by the VA as counselor to the ACR many years ago, and have had the opportunity to serve on a number of ACR committees, and know that the ACR has really strongly encouraged membership from VA radiologists. And so I wanted to focus this presentation to the ACR on some of the opportunities for collaboration and innovation with the VA. One of the best examples, of course, has been the fact that the Baltimore VA was the world's first filmless radiology department. And many things about the culture within the VA and information systems and electronic medical record made it possible that as we opened the new hospital in Baltimore, we were able to open it as the first all-digital enterprise. And this was strongly supported from VA national leadership, and it gave us the opportunity to do a lot of the initial research on clinical efficacy, economics, and even medical legal implications of digital radiology. Also had the first radiology electronic medical record interface. And so this is, I think, one of the best examples of where the VA had a unique opportunity to be able to really do some groundbreaking work in transforming the way that radiology is practiced. Another thing that we were able to do with the world's first filmless radiology department was to innovate in radiology reading room design with innovations in lighting, workstations, monitor, furniture, and even sound masking and other acoustic systems within the Department of Veterans Affairs by creating the Radiology Reading Room Lab. Other innovations have included the first 3D advanced visualization enterprise-wide system for radiology, nuclear medicine, and cardiology, the VA's Vista imaging system, including enterprise imaging into the electronic medical record, including pathology, cardiology, endoscopy, surgery, ophthalmology, dermatology, and other specialties, essentially the first enterprise imaging system. We've also done a lot of work with augmented reality and virtual reality, and we're early adopters within the US of 3D digital breast tomosynthesis. There's been a fair amount of innovation that's been fostered during the pandemic in remote image interpretation and also remote image acquisition. For example, exposing a patient in the next room by a technologist that's in an adjacent room. The VA has also performed early studies, for example, in lung nodule screening, with a large multi-center VA trial being one of the earliest trials looking at the implications of the National Lung Screening Trial recommendations. One really interesting example of innovation within the VA is the ability to rethink and reimagine doing plain film studies but using a CT scanner. And so the hypothesis was, what if we, starting with chest radiography, looked at doing CT scans instead, using a similar profile for dose or maybe even lower dose for CT than we use for conventional PA and lateral radiographs. And what if we had the capability to do this on a scanner that was actually less expensive than a high-end digital X-ray system? And what if we were able to maintain similar throughput and be able to create synthetic PA and lateral images, or be able to look at the full CT data set? And so the ability to do this without worrying about some of the reimbursement challenges that one would have in private practice or in academics is really a fascinating project. And being able to extend this from just chest radiography to abdominal radiographs, musculoskeletal imaging, spine, and other types of neuroimaging, has been a fascinating project. There was a workshop convened by the NIBIB at NIH looking at challenges associated with artificial intelligence adoption. And one of the things that was mentioned as one of the most pressing issues was the absence of large annotated medical image databases. The Department of Veterans Affairs, of course, offers huge numbers of medical imaging studies and is the largest integrated healthcare system in the US, with over 1,200 healthcare facilities, over 9 million patients enrolled currently, and with a tremendous amount of unique data, including electronic medical record, administrative, demographic, lab, genomic, and other data. The VA's Million Veteran Program became the largest genomic database in 2016, and currently I think there are somewhere around 1 million patients that are enrolled, and data within the VA is stored within a corporate data warehouse. And so the VA has moved forward with something that's referred to as the VA Data Commons, which is designed to promote access capability to this type of data outside the Department of Veterans Affairs. And so building a national VA Data Commons is the first step towards transforming VA data into a national resource. There's already a system called Vinci, the VA Informatics and Computing Infrastructure within the VA, that allows access to patient electronic medical records for research and also for administrative purposes. And that is supplemented by the Million Veteran Genomic Database as well. Both of these together represent an incredible research goldmine. And what I would very much like to see would be the VA do something similar to the medical image repository to make those available for cross-correlation with patient electronic medical record data and also genomic data. The Vinci project allows access to the VA's vast corporate data warehouses of information. And the VA offers a tremendous variety of different research tools to researchers and data space, and allows access to this huge repository. The VA has a system where a research study team can upload data, and then the VA's Vinci project can create a cohort for a variety of different types of research studies and potentially for clinical studies as well. The Million Veteran Genomic Project, in addition to Vinci, also provides the potential for a huge amount of genomic data to be cross-correlated with patient lab and other information in the electronic medical record. This project is quite a few years ahead of the recently funded NIH genomic project. And so there's the potential within the VA for tremendous access to this gold mine of medical images, which can potentially be cross-correlated with the VA's genomic and medical record data. The VA has also set standards for design and optimization with radiology purchases within the VA, resulting in a major impact on MRI and CT. And within the VA, there's been a number of different projects that allow us to be able to provide optimal care free of reimbursement constraints. For example, the use of PET-CT for infection imaging before it was widely reimbursable from CMS and the insurance providers. the CT replacement for conventional X-ray project that I was talking about, and then lung screening projects for abdominal aortic aneurysms, bone mineral density, digital mammography, and other types of screening programs. The VA has potentially huge resources to be able to be in access for not only medical images for deep learning, but also for cross-correlation with the VA's electronic medical record and also genomic records. And so in conclusion, despite popular opinion, radiology and nuclear medicine within the VA is practiced at a really high state-of-the-art level with tremendous innovation and flexibility. Research has been traditionally strongly emphasized at the VA, and I think the VA has huge internal resources, not just the data, but also compute and storage capabilities, and has huge potential in medical imaging. Decision support has been implemented at the VA well before other healthcare systems, and the VA's radiology and nuclear medicine leadership have been well organized and really strong in support of radiology practice and also clinical research and collaboration. So overall, it's been an absolute honor and privilege to serve our country's veterans, and I think the VA can be an incredible source of collaboration to the ACR and its members, given its resources and given its culture. So thanks so much for the opportunity to present.